Today we are going to take a look at major hemorrhage in the emergency department. We will look at up-to-date guidelines on how we can achieve the best outcomes for this critically ill group of patients. Now, major hemorrhage is classified as patients who have had a 50% blood loss within 3 hours, or patients with bleeding with clinical signs of shock. So this could be symptoms such as an increased respiratory rate, tachycardia, hypertension, or a sense of anxiety. Major hemorrhage is most commonly seen in patients who have been involved in trauma, patients with GI bleeding, such as bleeding in varices or ulcers, or in bleeding in pregnancy, such as ruptured ectopic pregnancies. Major hemorrhage is certainly not limited to these presentations, however, these are the most common ones that we find in the emergency department. Now let's take a look at how we declare a major hemorrhage in the emergency department. Firstly, we must identify those patients who are unable to wait for full cross-matching, i.e. they have lost that 50% of their blood volume. We take basic first aid steps to stop the bleeding, for example using pressure or tourniquets. Now most emergency departments will have a red phone or emergency number to the labs to declare a major hemorrhage. Once we have declared the major hemorrhage, we make homeostatic measures to improve the outcome. We will look at them in more detail later. We then administer Pack 1, followed by Pack 2 if the bleeding continues or the patient remains unstable. During this process, the patient is continually assessed. If we are satisfied that the bleeding has stopped and the patient is now stable, we alert the labs to stand down. Now let's take a look at what we should expect to find in our major hemorrhage packs. In Pack 1, we should expect to find 4 units of red cells and 4 units of plasma. And Pack 2, we should expect to find 4 units of red cells, 4 units of plasma, and 1 dose of platelets. Hemostatic measures can be as important as the use of blood transfusion products. Keeping the patient warm can be critical. The use of tranexamic acid and the reversal of anticoagulant medications such as warfarin. Avoid the use of crystalloids, as this can not only dilute the blood but also dislodge the body's first clot, leading to further bleeding. Some important things to remember with any critical situation are: the importance of communication cannot be understated. A lead should be identified early and they should liaise with the labs and assign roles. Blood group sampling may not always be possible, in which case O-negative universal blood will be used. Take 2 separate samples prior to infusion if possible. Once stand down has occurred, take time to ensure traceable documentation is accurate.